Welcome back to Therapeutics. Here we're going to talk about anemias and also drug-induced blood disorders. We'll differentiate the types of anemias. We'll review different treatments for those anemias. And also we're going to review some of the content we've already talked about earlier in the year about drug-induced blood disorders.
Anemias typically will present when the patient presents with a hemoglobin hematocrit, which is below the accepted mean for that patient. Men typically have a higher H&H than women on average. And you look at the etiologies of anemia, and usually it's one of these or a combination of these. It's either blood loss, so you worry about trauma, or a GI bleed, or an internal bleed somewhere else. Or it's a problem with decreased red blood cell production, so something maybe is suppressing bone marrow that suppresses production. Or there's a decrease in red blood cell survival. There's hemolysis or some other factor that is affecting the survival of red blood cells. And sometimes a combination of those. So whenever you get someone with anemia, you really want to do an appropriate workup to figure out what's going on and why. So let's quickly look at some drug-induced blood and blood disorders, specifically not so much hepatic, but blood disorders. And these are lifted right from summer slides. We talked about these already, so I'll go through these quickly. We have hemolytic anemias, thrombocytopenias, neutropenias, and aplastic. You remember we talked a bit about hemolytic anemia, hopefully, and this is when you have an increased rate in red blood cell destruction. It can happen in the blood vessels or extravascularly, and it's often related to a toxic effect or an inherited abnormality or some kind of an induced immune response, an idiosyncratic response. So the one big one we think about here is a glucose 6-phosphate dehydrogenase deficiency, as we alluded to earlier this year. And so that's something that would be looked at. And typically, folks with this hereditary trait are either northern Mediterranean or southern Mediterranean in ancestry. There are lots of variants of glucose 6-phosphate dehydrogenase deficiency. The type A is the less severe northern and Africa kind of phenomenon, and the southern European is type B, which is more significant. Factors that predispose to the hemolytic anemia in these patients could be non-drug, not related to drugs, but infection, diabetic ketoacidosis, or some foods, particularly fava beans. But there are a number of drugs that are known to trigger this as well. The drugs that do this typically are agents that are somewhat oxidizing and affect the integrity of the membrane of the red blood cell. They're listed here. The big ones we think of are the sulfonamides and quinine and quinidine, which are not used much anymore. And vitamin C, ascorbic acid, is another one that's sort of big on this list. The immune mechanisms involved in hemolytic anemia involve a couple of different processes involving either hapten-type reactions or immune complexes or an autoimmune kind of reaction. And the hapten type is the drug binds to the red blood cell and then triggers a specific immune response triggered to that hapten or that antigen that develops and results in hemolysis. We also have immune complexes formed, which also trigger lysis on the membrane of the red blood. And there's also an autoimmune type of reaction that can happen as well. Drug-induced thrombocytopenia is not uncommon, and we always look at patients' platelets, particularly in the hospital when they get exposed to lots of different drugs in different conditions. Thrombocytopenia can also be triggered by viruses, but when it's drug-induced, we can see it drop usually quite dramatically. It's often related to an immune reaction or a decrease in production by suppression of the bone marrow. And so the majority that we'll see, though, with thrombocytopenia that are drug-related are immune reactions that are similar in a sense to the red blood cell hemolysis. And you'll see a complex, immune complex form that results ultimately in destruction of platelets. This destruction happens, there's also suppression in thrombocytes as well that can be related to a suppression in production of platelets. There are a number of drugs that are associated with causing thrombocytopenia, but by and far the largest one, the one you'll be most experienced with in clinical practice, particularly if you work in acute care, is heparin. Heparin-induced thrombocytopenia is considered a medical urgent situation for which we stop the heparin, and it can actually trigger a whole host of other kind of effects, include affecting the entire clotting cascade. So we'll talk more about that when we get to coagulation later in the year. We also have drug-induced neutropenias. These are drops in white counts, and they're most often associated with drugs that are known to be bone marrow suppressing, particularly chemotherapeutic drugs. The older chemotherapy drugs are associated with significant neutropenia that happens about 7 to 10 days after the patient gets their cycle of chemo. And that's a risk for them to then develop what we'll call febrile neutropenia, life-threatening concern for an infection without able to host an immune response. The types of neutropenias that you can get are divided by immune-mediated or associated with accumulated drug toxicity in hypersensitive individuals, or a combination of those. And those kind of the classic thing you'll see in most of the chemotherapeutic agents that are used is the drug toxicity model. So we'll see some of the same kinds of mechanisms that can be an immune-based. There's a hapten reaction, immune complex formation, or autoimmune kind of reaction. These are similar mechanisms across the board. We see with platelets as well as with red cells, and you'll see this kind of similar kind of presentation with bone marrow suppression in white cells, or effects of white cell blood cells. We also have a type 2 accumulation of toxic concentrations. Again, we'll see this more often with drug that is known to be drugs that are known to be toxic. Another drug we'll talk about that is kind of is pretty severe here with bone marrow suppression is clozapine, or Clozaril, is an agent we use in mental health, and we'll talk much more about the bone marrow suppress and the REMS program that the FDA has required for patients on Clozaril who need to be registered and get regular white blood cell counts and absolute neutrophil counts done for them. We can also have situations where drugs induce a array of bone marrow suppressive effects, including suppression of red cells, white cells, and platelets. And these are very severe when they happen. And we look at all of the potential drugs that can cause it. Many drugs can cause this. Thankfully, they're very rare to see this kind of reaction happen, but important for us to differentiate what the issues are. So you'll see idiosyncratic mechanisms for this aplastic anemia, also immune reaction, and the treatment of choice typically is remove the offending agents and consider even a bone marrow transplant if that's absolutely necessary. But let's hope we don't. Thankfully, we don't see this very often. We also are looking at factors that affect red blood cell production as a function of anemias. And when we have a problem with red blood cell production, typically we look at the precursors that are involved in requiring the production of red blood cells. Those include iron, B12 folic acid, and erythropoietin, which stimulates red blood cells. And we'll talk a bit more about this also when we get to the renal block, because folks who are in renal failure require erythropoietin, and to make sure they have enough of the precursors, particularly iron, on board to make red blood cells. Iron is essential, and we'll talk more about this again in renal block, but typically the body has a limited store of iron, really 3 to 5 grams, and most of that exists as hemoglobin in red cells. Otherwise, there's not too much other body stores of iron. The issue, though, is you've got to think if somebody's iron deficiency, most likely it's because they're losing blood somewhere. And you'd expect for menstruating women to lose blood, but everyone else you would not expect a lot of blood loss. And so you want to be clear that if you see iron deficiency and you want to explain why is that, where are they losing blood? If you're seeing an iron deficiency-based anemia, then your question really needs to get around where is the blood going. So appropriate before you just throw iron at a patient, you also do an appropriate workup for where is that blood loss happen. When you look at iron absorption in the gut, about a third of iron that's ingested is absorbed if it's related to a blood product. So, for example, iron in meat is typically absorbed better than other sources of iron. But vitamin C also is associated with, concurrent with iron, is associated with improved iron absorption as well. And so sometimes we look at vitamin C supplementation in folks on iron, although the data for that is moderate, not superb. We also look at iron transports, particularly transferrin, and can be reported as transferrin can be reported as a total iron binding capacity. And you want to look at is if someone is anemic, particularly what are their iron stores? Do they need iron or not? You don't want to supplement iron in someone who is not iron deficient, because iron, other than bleeding, has really no way of getting out of the body. And very high levels of iron can be associated with all kinds of toxicities, including GI toxicity and also hepatotoxicity. So iron storage from transferrin is either used in heme synthesis or stored as ferritin. And typically you'll see a turnover about 1% of red blood cells destroyed daily, and that iron, most of it is actually recycled or remains in stored iron stores in the body. So for the most part, most folks do not require excessive iron supplementation, and in fact, excessive iron supplementation could be problematic. When you diagnose iron deficiency anemia, typically that's going to present with a low hemoglobin hematocrit, but also a microcytic hypochromic red blood cell. Microcytic, smaller size cell, hypochromic, pale-looking cells. They also will have a low mean corpuscular volume and a low mean corpuscular hemoglobin concentration. Their ferritin levels will be low. Their total iron binding capacity may also be low. There are a number of iron salts. The ferrous salts are absorbed better than the ferric salts, so most of the salts you'll see given orally are ferrous. The most common one you'll see is ferrous sulfate, although maybe the one that is best tolerated is ferrous gluconate. The issue is you want to also look at the amount of elemental iron you're supplementing a patient. So you typically would look at, if you're given ferrous gluconate, which has a little less GI upset, you're also getting a lot less elemental iron associated with that dosing. But those are pretty common formulations. Ferrous sulfate is probably the most common one you'll see folks use. And the issue is with any of these iron products is we often, if we have the luxury of time, which you usually do, to start off with a single dose a day with a meal, and then go up over the next couple of weeks to twice and then 3 times a day with meals. Even though the iron may be absorbed better on an empty stomach, the issue with that is that most folks won't tolerate it. They'll have nausea, they'll feel lousy, and you want folks to adhere to therapy. So the dosing, typically we'll look at when you need iron. Typically you don't need more than 2 to 6 months of iron therapy. Unless they have a chronic blood loss, you want to keep an eye on this. You don't want to give them too much iron. Typically you're going to dose 2 to 3 milligrams per kilogram per day of elemental iron. So go back to look at that chart of what's elemental. And you look at the typical dose of ferrous sulfate, ultimately is something like 300 milligrams 3 times a day. As you increase the dose of iron, you also will see a decrease in absorption, so you really want to split the dose to not more than like 300 at each dose for ferrous sulfate. The adverse effects of iron: abdominal distress, constipation, pretty common, nausea, rarely diarrhea. And to avoid the GI intolerance, people often will have, again, low dose to start, usually with a meal, even though absorption may be a little lower with a meal, and increase that gradually over a couple of weeks. You are always thinking about iron overload when you've got patients who are on iron therapy, so you want to make sure that you're looking at potential concerns for iron overload, both in acute ingestion, one of the toxicity manifestations, for example, of iron overload. If a child, for example, took an overdose of iron tablets in the medicine cabinet, that's a real concern. But long-term chronic overload with chronic iron administration without deficiency is also a problem. So if you inherit a patient who's on daily iron supplementation for years, you really need to do the full panel of iron and anemia and find out why they're on continuing iron. Do they have an ongoing blood loss that explains that, and you're addressing that blood loss issue or not? And then there's toxicity management for acute toxicity with deferoxamine, which binds iron. That's our antidote for iron overdose. Parenteral iron, we won't really talk about much here. We'll talk more about this when we get to renal failure, because those are really the only patients who really typically require parenteral iron. Those are the folks who are pretty iron deficient, and the folks in renal failure almost always require iron supplementation given intravenously while they're at dialysis. And we'll talk more about that when we get to the renal block. And the formulations, we'll talk again about these more later in the year. In the renal block, there's iron dextran and there's ferric gluconate. We'll talk about that. I'll give you the slides here, but you'll see these again in renal. Again, you'll see ferric gluconate in renal. And the comparative iron formulations, again, we're going to reserve our discussion here until we get to the renal block. Another consideration with anemias is whether somebody has a B12 deficiency. And often this is inactive ability to absorb vitamin B12 because they might have a deficiency in intrinsic factor. And years ago, we always gave for B12 deficiency anemias, which present as a larger red blood cell, an increased mean corpuscular volume, and a low B12 level. We used to always just give an injectable B12, but now our treatment modalities are almost always just oral, but very high dose oral. So while you need an intrinsic factor will facilitate the absorption of a low dose of cyanocobalamin, a B12 in the gut, if we really overwhelm that with quite large oral doses, you can get some passive diffusion of B12, which is enough for patients to get an improvement in effect. So B12 deficiency, typically they'll be present as macrocytic anemias, and the worry about untreated B12 deficiency is also a neurologic complication of B12 deficiency with a demyelination of nerve cells, which can result in paresthesias in the hands and the feet, and can also contribute to hallucinations and delusion and dementia. One of the classic workups for a patient who has a change of mental status, an older patient with dementia or looks like dementia, is a B12 test. And it's quite remarkable when you give B12, you see a real improvement in these folks. It's pretty rare to see it that significant, but it's a rewarding thing to see when you treat it and you see that dementia improve dramatically. We also have folic acid deficiency seen in green leafy vegetables. Folic acid deficiency is seen also pretty commonly in acute alcoholism, so we often will give folks who come in with alcohol history folic acid and thiamine. We'll talk more about that later in the year. Folate deficiency also presents like B12, looks like B12 deficiency with a macrocytic anemia, increased mean corpuscular volume. But the folate supplementation will make the anemia look better, but it won't address if they're still B12 deficient, it won't improve the neurologic consequence of B12 deficiency. So typically when you see someone with anemia, you get iron studies, you get a B12 studies, you get folic acid assessment, and typically you're going to give folks with a macrocytic anemia a B12. Usually they're B12 and folate deficient, and folks who are microcytic anemia with iron deficiency, you'll get iron replaced in our iron stores. Later in renal block, we'll talk about erythropoietin, which really almost the only reason we give erythropoietin, which is the glycoprotein naturally produced in the kidney that stimulates bone marrow to produce red cells. We use this particularly in renal failure. It can also be used in folks with advanced HIV or oncology patients, but those are quite rare these days. Typically, it's limited to patients with renal failure, and we need to also give adequate amount of iron. We'll talk more about our goals for hemoglobin, which are not quite as robust as full normal levels based on negative outcomes with sort of shooting our goals a bit too high with erythropoietin. And the FDA used to have a REMS program on this. I think they've just suspended that REMS program in the last year or so. The adverse effects for elevated erythropoietin dosing is hypertension, fatigue. This is also a drug that is potentially abusable in sports medicine, if you remember all of the concerns associated with Lance Armstrong, for example, and the Tour de France. That was an issue as well. As we look at a couple of other last quick things, we'll talk about these other agents more so in oncology. Filgastrum and Neupogen and variants of this are colony-stimulating factors for neutrophils and or granulocytes. We'll use these agents post certain chemotherapeutic regimens that have significant bone marrow suppression, so more about this later. The kinetics, we'll talk about them, but they're typically given subcutaneously. Most folks are now on a longer-acting formulation of filgastrum now that instead of having to be dosed every day or dosed once on the day after chemotherapy cycle is complete. And then leukine is a GM, granulocyte macrophage colony-stimulating factor that could also be used post certain chemo, but in practice we don't see this used much at all. And finally, there is a colony-stimulating factor that improves platelets, but unfortunately, because of significant fluid retention and heart failure associated with it, it has had a very limited use, and so most folks instead would do platelet transfusions. And the drugs for which we expect you to know doses are listed here. Finally, in the next set of slides, we're just going to give you a review of some of the CDC recommendations for some of the common HEENT issues.